Don't worry about the slides, they're a bit text heavy, and that was just so that everybody can follow, and when you go through the slides later on you have everything that I've said, so don't worry to read them now, it's a lot. I just put it all in there so that you have it later on, especially if you don't follow my English well. Right, so I am the Senior Acute Pain Fellow at UZ Leuven in Belgium. This is my hospital, Gasthuisberg. It's a very large hospital, about 9,000 staff members. We have 50 operating theatres in the main theatre complex, and then the day surgery has 16, and we have an interventional suite with another 12. So we do lots of surgery, and we do lots of regional anesthesia as well. People equate us to a sausage machine where you put in the sausage, you know, to just get the patients through, and it is a bit like that sometimes, because each and every one of us takes care of a specific part of it. So the acute pain and regional is part of mine. I'll be talking about knee surgery and the strategies around pain management in knee surgery. I'll focus mostly on total knee arthroplasty, but I will give you some strategies for other things, knee arthroscopy, anterior, posterior cruciate ligaments as we go along. So firstly, just why is it important? Because knee surgery is one of the most common orthopedic surgeries happening. And the problem there is that about 30% of patients experience a very large amount of pain post-operatively. So this means one of two things. Either that the surgery is really painful, we know that, but we're not managing the pain as well as we can. And the problem is that when you look at the protocols from each center, every center has a different protocol for managing knee surgery. So that's one of the problems that we find. With this comes with pain, we have delays. We have delays in patients that cannot be sent home. We have delays in hospital, and then we have complications because of the delays. We have venous thromboses, we have other complications, falls, infections that all increase. So what we want to do is have a patient comfortable, as pain-free as possible, home as quickly as possible. Right, so in this, keeping that in mind, just look a little bit about what techniques. Now there's lots of techniques. There's just a general. You can use local infiltration, peripheral nerve blocks, epidural, spinal, you know, there's lots of things described. And what I will do today is take these step by step and tell you what the literature says about these approaches and what protocols are specifically indicated for specific types of knee surgery. So the femoral, I'm just going to skip through these, we'll go through them in detail just now. Just to remember about the anatomy of the knee, I won't spend much time on this, we just have an anterior and a posterior compartment, and the important parts for knee surgery is especially the femoral component, the saphenous nerve, and the quadriceps. That is the main contributors. We have minor contributors as well that can have an effect on pain, but that's the big contributors. And the posterior compartment, the sciatic nerve, we have different contributions for different things. So once you think about doing regional anesthesia for knee surgery, you have to think, what is this surgery? And what part of which compartment is really necessary to block, to have this patient pain-free and mobile. So, just a quick anatomy again. This is without the patella now, the anterior view, where we have the femoral branches, as well as the contributions of the tibial and common peroneal, and then also the deep obturator or posterior obturator tibial nerve, and the common peroneal nerves that come into the popliteal plexus, also the recurrent part there. So different strategies, as you had the lumbar plexus and the psoas compartment block would be over here where you blocked it. fascial block, femoral block, obturator, the adductor canal block, and you could do peripheral block as well, but we won't go into that. Then posterior compartment, the epidural anesthesia, spinal. We have another one here that I'd just like to add. That's the parasacral sciatic nerve block, the transgluteal sciatic nerve block, and you know, we can also do a popliteal block later. Okay, so the plan. Now, don't worry, lots of writing. Don't read it all. You can read it home. So there's various methods that we do for pain control, and the idea is to use a combination of pain medications and strategies to minimize the complications of each individual drug. So if you just give morphine to a patient, that's fine. They'll be fairly pain-free, but they'll be vomiting, not breathing, well, and lying in a stuporous state. But they won't be unhappy, but we want them happy and be able to move as well. So the post-operative management of pain is, and to reduce opiates in this process, because I'm not sure how big it is in the Ukraine, but America has now got a very big opiate problem, opiate addiction. It's coming to Europe as well. We're seeing it more and more. These patients get addicted. They have a painful surgery, which is a legitimate reason to use opiates, but then they continue using them. And that's where the problem starts. So our center and lots of the other centers in Europe have now started moving away from opiate anesthesia due to the complications, the nausea, the vomiting, the sedation that the patients have, and the risk of this opiate addiction. Then, okay, so firstly, next one. There we go. All right, so once we look at strategies, we have three basic patient groups that come for knee surgery. You have the healthy patient, that's mostly nothing wrong, for a primary knee surgery, or a simple knee, knee replacement, simple one joint. Then we have patients who have chronic pain that are already on opiate therapy or already on strong medications that come for their knee surgery. And the last group is the complex surgeries, where you have multiple previous revisions of things, where you have previous infections of a replaced joint, things like that. And each of them have specific criteria and specific things you have to look out for. So firstly, the healthy group, we want them to mobilize and go home as quickly as possible and keep them pain-free. So we don't want a motor block, because we want them able to move, and we want them pain-free. So for these ones, we would do more peripheral nerves and do motor sparing nerve blocks. So I'll go into detail about those just now. Then the chronic pain patients, they're not for fast tracking. They're already on lots of pain medication. They won't get out of bed quickly. So these patients, you would do longer acting blocks, motor blocks, and add catheter techniques or spinal epidural techniques for these men. So for them, it is more important to keep them pain-free so that you do not feed opiate addiction. Next up. There we go. All right, and then the last patient is the patient who undergo complex joint reconstructions, repeat surgeries. And for these patients, they would also not mobilize quickly afterwards. So for them, it's really important to make sure that they have the best pain management strategies or long-term pain management strategies, because some of them will need repeat washouts of septic knees, repeat surgeries. So for these patients, you have to think long-term pain management with a combination of blocks and combination of opiate and block plus catheter techniques. Okay, first strategy, the local infiltration or periarticular infiltration, which is mostly done by the surgeons. It's very popular. All the surgeons think they're fantastic because their patients are very happy afterwards. But the problem with this is the surgeons use very large volumes. I didn't put it in here, but they can use anything from 80 to 200 milliliters of local anesthetic in some centers. And if you give 200 cc's anywhere in the body, you'll probably block something, and the patient will be pain-free to a more or less extent. So I'm not too happy with this amount being injected. And something that I've also noticed, the local anesthesia injection or infiltration anesthesia, for me, LIA means lying in agony, because it works really well post-operative. The surgeon goes to them in the recovery room, they're happy. About 6 hours later, the patient is lying in agony. So this is a great technique because it does spare the motor nerves, but you have also complications of it, local anesthetic toxicity, and you could injure, they do it under direct vision, but you could still injure the nerves. So this as a strategy, we'll go through comparing this to the others as well. Then peripheral nerve blocks. Now this is why you're here. This is what we're going to do, peripheral nerve blocks. It reduces the pain, it reduces opiate use. This has been proven in several studies over the years, over and over. It's good to use as part of a strategy, whether you do a general plus a block, just a block, whether you use spinal anesthesia as your primary anesthesia and add a block for pain management afterwards. This is a good way to manage pain. Firstly, femoral nerve block. This is the stock standard. It's the workhorse of knee surgery analgesia. Femoral nerve blocks are easy to do, the anatomy is easy, and they work well. When you look at just the associated motor block, it is significant. You get quadriceps fallout, complete quadriceps fallout of after doing a femoral nerve block. So that is one of the things that you have to think about. It's very suitable for patients that aren't going to mobilize early, that you do not expect them to move or walk or get out of bed. Then also placing a perineural catheter is also a very easy technique with a femoral nerve block, and you can do a bolus technique plus the catheter for femoral nerve blocks. The complications of femoral nerve blocks are very small, and we do femoral nerve blocks plus catheters in all complex surgeries. So if we have a repeat surgery, revision surgery, patients who are already on lots of opiates, we do this for all the revision surgery patients. The surgeons still want to do their local infiltration as well, so we let them, but we'll talk about a better technique. Then your adductor canal block. This is specifically for the patients that you want to mobilize quickly. So if you look at the literature, the adductor canal block is supposed to only block the saphenous nerve, the nerve to vastus medialis, and a little bit of the deep obturator nerve. Mostly you do not get that as well, but it has been quoted in the literature. And it's performed midway between the patella and the anterior superior iliac spine. If you look anatomically, I have a little bit of a problem with the adductor canal description. It's actually the distal femoral triangle. The adductor canal is just a bit lower, but I'll show you that in the sessions later on. So if you do an adductor canal block, the only motor part that you do block is the nerve to vastus medialis, which doesn't give you much power, and the patients can mobilize quite well. But you still block most of the pain sensation to the knee, which is great. If you compare them to both single injection and femoral nerve block or continuous nerve blocks, they are inferior pain management-wise, but they are far superior if you want to mobilize your patient. So it is a good strategy to add. It doesn't make a big difference whether you add a catheter or not. And the other thing to remember is if you give a large volume in the adductor canal, you're basically doing a femoral nerve block because it will just spread out. Okay. Sciatic nerve blocks, whether you combine with a femoral nerve, it gives excellent pain control. Problem is if you do a sciatic nerve block as well, the surgeons do not know whether there's foot drop. So one of the surgical complications of a knee replacement is obviously injury to your sciatic nerve. So the surgeons don't like us doing sciatic nerve blocks. But sciatic nerve blocks work very well in combination with femoral nerve block for pain management. And that is definitely an idea for patients who have complex surgeries and you don't want to do epidural anesthesia for these patients. We do catheters, femoral and sciatic catheters for these patients. They do very well pain management-wise. What we do tend to do is to put in the catheter, and we call it a dry catheter. So we do the block, the sciatic nerve block, with saline. The surgeon comes and evaluates the motor function of the sciatic nerve after the surgery, and if it's fine, we load up with local anesthetic, and then the patients are free. So it's just that little period post-operatively that the patient is in a bit more pain, but we cover that with normal analgesia. The problem as well with sciatic nerve block is it lasts very long. It takes a long time to start working, so you have about 30 to 40 minutes, sometimes even up to an hour before you have a good working sciatic nerve block, and it can last more than 24 hours, and it can cause post-operative neuropathy, especially in patients with diabetes or other small vessel diseases. So that's a big risk. So if you just want to use it for pain, use low concentrations of half strength, ropivacaine, bupivacaine, whatever you're using. Okay. Then lumbar plexus as well. The lumbar plexus or psoas compartment, as was very well tells you about by my colleague now. This can definitely be used, but mostly for hip surgeries. It's not the best kind of anesthesia just for a knee surgery. And if you look at studies comparing lumbar plexus with femoral nerve blocks, with adductor canal blocks, you don't have much extra analgesia for a knee if you're doing those blocks. So they're about equal in how well they work. So rather pick the least invasive one. But if you want to do higher surgeries, hip surgeries, by all means it's a very good block to do. Then going to the Ipaq block, the interspace between the popliteal artery and posterior capsule. Now this is a new kid on the block for knee surgery. This only blocks the posterior capsule of the knee. So you do not get sciatic nerve fallout, so your patients don't have any motor fallout, but you have good pain relief in the posterior capsule of the knee, and this in combination with a femoral nerve or adductor canal block will block your knee to a very good extent. Your patients will have minimal pain afterwards. This block is performed in many institutions, and we do it as well. We've started doing it for the knee surgeries, and we're doing it for all cruciate surgeries and complex knee arthroscopies and so on. We're doing that as well. Then looking at the obturator nerve block. Now the literature on obturator nerve is very conflicting. Some literature says by adding it you get decreased morphine use, etc. Other studies have shown no added benefit. So we do not routinely block the obturator nerve. It's mostly not necessary in our daily practice for knee replacement surgery. Then a little something about patient falls, because you're going to hear the surgeon say, oh, you've done regional anesthesia, now my patient's weak and he falls. And there's an increased risk of falls and it's been proven in literature. It has not been proven in literature. The literature has actually said the opposite. So there is quadriceps weakness, but that's not the only factor in falls. The larger factors that cause patients to fall is the comorbidities, the effects of surgery, the age of the patient, and in a recent meta-analysis they found that the BMI of the patient has more to do with the falls. So fat people fall down more often, is basically what they found. Another database that's been going, and it's still continuing, and this is just the last figures that they've published, 191,000 patients undergoing total knee arthroscopy, total knee arthroplasty, and in 400 hospitals in the US for a 4-year period, they found no difference in falls on patients who've had blocks or patients who've had no block. The block patients was 1.58%, and the patients who've not had a block, 1.6%. So no difference, no statistical difference in falls. So you can quote that to your surgeon. Then continuous versus single shot. There is a benefit if you want the block to work longer doing the catheter techniques. But catheter techniques come with their own problems. The longer you keep in a catheter, the bigger the risk of infection, and especially in the femoral region, you have a risk of infection. So catheters are also costly and labor intensive because somebody has to follow it up. You can't just put in a catheter and hope it goes well. Somebody has to follow up the patient, and if a complication happens, then the patient has to be able to phone or to contact somebody 24 hours a day. So even if you send them home with catheters, they should be able to then phone and say, oh, I feel a bit dizzy, or I feel, or I taste something funny in my mouth, you know. So if you do place catheters, there is a risk of that. If you look at pain management-wise, only for complex knee surgeries or repeated knee surgeries is a catheter actually indicated. There is no big difference in versus, single shot versus continuous nerve block in simple surgeries. So if you do a simple knee arthroplasty or simple surgery, it doesn't really show in the pain scores, and it doesn't show on the decreased opiate usage. It's only with a complex surgery where it does make a difference. And then other studies comparing continuous adductor canal blocks with femoral nerve blocks just shows that you mobilize better with adductor canal, but the pain is a bit more. Then neuraxial techniques. I'm not going to spend much time on this. Neuraxial techniques, you know them, you've used them. We usually use them as a primary anesthesia for the patient, and then we add local or regional anesthesia for pain management of these patients. So we would do a spinal plus a femoral nerve block, or a spinal plus a catheter, this femoral nerve catheter, or a abductor block. So we combine them. Also, I'm not going to go much on that. So best practice for the other surgeries. So we've talked a lot about what we do for simple knee surgery, for chronic pain surgery, and then for patients with complex knee surgery, and that's all arthroplasty-wise. But what about the other things, other interventions? Knee arthroscopy alone, if they're just putting in a scope, it's a bit overkill unless you use the regional anesthesia as the sole anesthesia. It's a bit of an overkill for just an arthroscopy. The surgeon can infiltrate the port, and that's enough. It's not very painful. You just do the normal general anesthesia. It's quick surgery. It's 15 minutes, 20 minutes. If you do a block lasting 12 hours, 24 hours for a patient who has 15 minutes in theater, you have to think, why am I doing this? Then patella surgery, if it's a simple patella surgery, you can use an adductor canal block. It completely blocks the entire patella. Patients are happy. If it's a complex surgery, where they have to do patellar reconstructions, Then we do a femoral nerve block for these patients. They're in any case not going to mobilize afterwards. Then anterior and posterior cruciate, we do an adductor canal block with an Ipaq. These patients do fantastic post-operatively. They have zero pain afterwards. They do very, very well. The only thing that you might need to do is to add an obturator nerve block if they do an autologous tendon transfer. So if they do take part of the tendon to fix the posterior cruciate, then you'll have to add an obturator nerve or ask the surgeon to infiltrate the part of the tendon where he takes the graft. If it's another graft, a synthetic graft or a cadaver graft, that's fine. You don't have to add the obturator nerve. Then corrective osteotomies. For knees, we do a combination of both femoral and sciatic nerve blocks for these patients. Okay. If you have any questions? Yeah. Okay.
Та виходить чітко, щось розуміє.